Hello, I want to welcome you to Ethics and Confidentiality in Substance Abuse and Mental Health. This is a workshop training created by First at Blue Ridge and myself, Linda Harrison. John Sanders is behind the camera, and he is also the editor that creates the online training that you're watching today. I want to just show gratitude or express gratitude to everyone who made this online training possible, and especially to you, the viewer, who utilizes this to help yourself maintain your professional licensure and certification, as well as create a strong and professional practice. So welcome. All right, we're going to begin with writing down an ethical or legal concern. So I invite you to stop this video training and to just take a few minutes to contemplate. Over the last few days, weeks, months, even year or years, what is an ethical violation that you have witnessed or experienced in your practice? And why I ask you to stop and to contemplate it and write this down, I think it'll be very helpful for you to reflect on that violation or violations, so that as we talk about ways to explore and understand and resolve ethical dilemmas, that you actually have an ethical violation or dilemma to work with. So I invite you to stop your video now and write that down, and then we'll move forward. So starting back, since you've now written down your ethical or legal concern, being specific to what concerns you most, also thinking about and adding to it if you were able to report that particular violation, and if so, were you successful in supporting more ethical behavior to occur? So the behavioral health ethical concerns that we'll be talking today are primarily, again, ethical concerns or behavioral health. We will begin to move just a little bit into medical as well, because many social workers and counselors work in medical settings. Secondly, make a decision about how to get support around your ethical or legal concern. Do you have an immediate clinical or administrative supervisor that can help you? I think one of the first things that I'd like for people to think about and learn from this training is, when I suspect an ethical violation, where it's one that I've committed or I've observed in someone else or in the agency, is who do I go to help me sort that out? Who do I go to get their support? So, keeping that in mind, let's move forward to understanding ethics and defining ethics. Ethics defined in relation to culture. In mental health care, ethics and culture are intimately intertwined. To practice ethically requires awareness, sensitivity, and empathy for the patient or client as an individual, including his or her cultural values and beliefs. So again, knowing the populations of various cultures that reside in your area, it's really important to know what cultures are there, who might come to your office or for your services, and to understand some of their cultural values, and being aware of how to support cultural diversity. In the area of North Carolina that we're in, Western North Carolina, there's a Native American population, the Cherokee. Of course, we have indigenous mountain folks, which have a culture of their own again. We have people who are from and live in the city and have very much a city culture. We have folks who are African American, of course. We have many folks moving into the area who are Asian, and understanding and knowing their culture as well. So that regardless of who comes and sits across from you for services, that you're aware of the cultural diversity and any biases that you might have. Cultural competence is practical, concrete. It's a demonstration of the ethical principles in respect for persons, beneficence, which means doing good, non-malfeasance, not doing harm, and justice, treating people fairly. They're the cornerstones of modern ethical codes for the health, mental health, and medical professions. So one of the first areas we'd like to explore is recognize and work within the power differential. The power differential notes that when you are providing services, counselor to client or supervisor to supervisee, that there is a power differential between you because the person who is supervising or providing the service, they're looked up to. They're seen as someone that has power and can help or hinder their growth and healing. And so the first we want to examine is the client to counselor power differential. The client comes to the counselor for assistance, not knowing, obviously, and many times, how to help themselves, how to heal from addiction, or how to heal from mental illness, how to recover. And so the client is very vulnerable and looking up to the counselor or social worker, needing their support, understanding, and treatment. And so again, the counselor needs to be aware of that power differential and not to abuse that power. The next power differential I'd like to look at is the counselor to supervisor. Again, I'll often refer to the counselor or social worker as a supervisee, and that relationship is to the supervisor. And so that supervisee feels that power differential because they need that supervisor to work with them, to assist them in developing the skills to become certified or licensed and to have professional integrity. And so again, that supervisor has a lot of responsibility to monitor and guide and support and advocate for that supervisee, counselor, social worker. The next power differential is the supervisor to the governing board and professional board. So that supervisor then, based on their performance, follows the guidelines of the governing board of that agency or the professional board with which they hold a license or for which they hold a license, such as the North Carolina Substance Abuse Professional Practice Board, National Association of Social Workers, or the state organization, and the licensed professional counselor state and national organizations. So that supervisor, often supervisors will be, will have a dual certification or license. The Substance Abuse Board offers a Certified Clinical Supervisor certification, and the North Carolina LPC Board offers a Licensed Professional Clinical Supervisor license or certification. And so going to a supervisor that holds those certifications ensures more professional care, and it requires a contract for completing that certification or licensure. There's the power differential of the governing board to the professional board and or legal system. So your governing board at your agency definitely has to respond to the professional board, which also could be the management care organization, who develops policies and procedures for handling, managing care and handling the use of state and federal monies as they come down to agencies for treatment for mental health. So that, again, the legal system also has specific criteria that govern the professional board and govern the board that the agency responds to. So as we see these power differentials, it's really important to know that all the way from the legal system, all the way down to the client-counselor relationship, that these are all in place to support ethical and legal considerations that every individual is able to get the care that they need. So moving to the next slide is approaches to ethics. So there's 4 approaches to ethics we want to look at. The first is normative. Understanding and recognizing what is normally acceptable in my profession for my behavior. In other words, what one social worker does should fall within the guidelines of their agency and their licensure board, and what's normally acceptable should be also true for another social worker, and that goes for counselors as well. So if one social worker carries out a specific task, both ethically and legally, and it's expected and normal, then we expect that to be across the board. And so when we look at the approaches to ethics, if somebody does something that's a possible ethical violation or there's a gray area, then that supervisor might say, or that board might say, so what's normative? What's normally acceptable for other people in your profession to do in that particular situation? So that's a good kind of, and we'll talk more about this, kind of an acid litmus test for if something is ethical or not. The next approach is common morality. What does society hold to in accepted standards of morality? So as we look at what our society holds as acceptable standards, that again also can be cultural, we want to look at what is a common morality. A common morality is that a counselor is not intimate with a client. A supervisor is not physically intimate with a supervisee, that we believe we have a common morality of healthy boundaries and not using or abusing the power of the relationship to involve someone with less power in an intimate relationship or a dual relationship where there's a personal and a professional relationship. So what is held as common morality? The third is codes of professional ethics. The American Counseling Association, National Association of Social Workers, National Board of Certified Counselors, North Carolina Substance Abuse and Professional Practice Board all have codes of professional ethics that are rules and guidelines that help form and help us understand what is within those normative and common morality and professional ethics. Governmental guidelines, public policy, and agency policy is next. So again, recognizing that there are governmental guidelines. The North Carolina state boards fall under the North Carolina Attorney General's office. And so it all trickles downhill from there. Again, if it's legal, it may not be ethical. So we have to really be aware that we sort that out. So looking at public policy and agency policy and procedures to make sure we stay within those guidelines is very, very important so that clients can get the care that they need and that they truly have a positive outcome. Next is Kitchener's model of ethical formation and reflective judgment model. Ethical theory leads to ethical principles. So we have theories that we create about what is appropriate in the care of an individual, whether it's behavioral health or medical. What are the theories that lead to the principles? So one of the theories is that people who are cared for at all levels, and we respect cultural diversity and that type of thing, are more likely to heal and become therapeutically conscious and able to make changes in their life that allows for healing. And when that theory leads to principles, then those principles of respecting cultural diversity leads to ethical rules and guidelines around recognizing cultural diversity, receiving education in that, recognizing our biases, and making sure we do not act on any biases. So again, how theory leads to principle, leads to rules and guidelines, and that leads to just an intuitive level, which is immediate action based on our own sound judgment of common sense and intuition. And that's really, really important. It really boils down to that. I think for me and for many individuals, it's really important to recognize if something's keeping me up, waking me up at night, and I'm concerned about something that's happening to or with the client that has to do with a possible ethical dilemma. If I have butterflies in my stomach, if I feel kind of what I call an ick factor, I get a bodily somatic sense that something's not right, then I need to explore that. I need to investigate. I need to gather information, and I need to pull in those people around me that I work with who I trust their judgment, who have good, strong personal and professional values to help me explore this and understand it. And if I need to go beyond that, I might contact the American Counseling Association's ethics support or their attorney, or request a contact with their attorney. So again, I go back to theory leads to principles, to rules and guidelines, leads to just good common horse sense or common sense and our own intuitive level of what is right and wrong based on our personal and professional values. Next is the 4 principles of ethical decision making. And I said 4, but I have 5 listed, so I need to make a change in that. The 5th has recently been added by many organizations, and it's fidelity. So we'll talk about that. So many of you may not have heard that one. The first is autonomy. And before we'll go into each one of these specifically. Their autonomy, beneficence, non-malfeasance, justice, and fidelity. For questions that assist with ethical decision-making, explore each one of those areas. So for me, rather than say what it is, let's ask some questions that will help us explore an ethical dilemma. So number 1 is the counselor giving the client the freedom to make choices about his or her direction and treatment. If the answer is yes, you're in good shape. If the answer is no, then what do I need to do to support the autonomy of the client? And so an example of that might be for the client, let's say, comes into treatment and they can only come to night SAOP, but there is no transportation. And so is the counselor able to talk with them about that and help them find transportation? Or does that counselor go, they're just going to have to figure it out. They're just going to have to come today. Well, and then you find out that maybe that client has a job during the daytime and they want to keep their job while being in treatment. So it's really important to advocate for that client's autonomy and support them to find their own transportation or to get to the first group and to find perhaps and share transportation with someone that is coming to that group. So autonomy is really important to support the freedom to make choices. Is the counselor providing hope, encouragement, and support for the client's decisions that are individualized, in line with the client's values and in the client's best interests regarding change towards successful recovery? In other words, are we able to provide hope and encouragement and support and the decision and the client to make decisions that brings about the benefit of the client? So sometimes we get to thinking that we know best as counselors or supervisors, and we may want to encourage clients to make decisions that are more about what we think they should do than what the client is ready to do. So what truly benefits the client? We really want to ask that question and make sure if we are doing it for the benefit of the agency or what we think should happen and not starting where the client is at, then that would be unethical. Number 3, is the counselor working with the client in a way that will do no harm, non-malfeasance? And so that's really pretty much, do no harm is right at the heart of all ethical decision making and sorting out dilemmas. Will someone be harmed by this that we're seeing? Is this an ethical violation or not? We ask ourselves, is someone being harmed? And it doesn't have to be horrific harm. It could be simply the harm of making that person feel like they can't make a decision or their judgment isn't right for them. And again, really recognizing that that client may need to make some mistakes. That client may need to sort things out for themselves and learn from what they're doing. We can talk with them, guide them, support them, but ultimately a client has to live their own life. And so to recognize that we don't want to do harm by having our own agenda, by forcing or shaming them into doing something that they're not ready to do. So to do no harm is really the hallmark, the central, the core of ethical responsibility to the client. Fourth, are ethical codes, laws, and universal values being followed by the counselor? And is the counselor providing fairness to all that are involved with the client's treatment? This is justice. So justice for all clients, justice for all supervisees, to be able to understand and know what ethical codes apply to them, what client rights are, what laws apply to them, what are universal values that apply to that client, to their treatment. And so justice or fairness to all is hugely important. If we provide services for one culture and not another, if we believe that one culture is less smart or deficient than another culture, again, that's highly unethical. And to base our treatment on that would be even more unethical. Number 5 is the counselor displaying faithfulness and honoring commitments to support the therapeutic relationship. So again, if we kept somebody in treatment just because they pay better than another client, let's say a sliding fee scale, agency you work for says, I need you to get rid of the dead wood, I need you to get rid of X, Y, and Z, plus they're at the bottom of the pay scale, that would be highly unethical. So again, are we faithful to the client and the therapeutic process where we recognize each person has the right to grow, learn, and heal and get on with the business of their lives? So really supporting that therapeutic relationship. If you see a client's very disturbed by something you might have said that they misunderstood, do we ignore them or do we talk with them and help them understand and explore if they heard and understood what we said and not what they thought we said? We're now going to look at some case studies to help you apply some of the things that we've talked about. And reminding as we go along to make some notes. You've got the slides to look at, which the quiz questions come directly from those slides. But sometimes it's helpful to make a few notes, so I encourage you to do that. The first case study is you're having your house painted. You arrive home from work early and see that one of the people that is painting your house is a former client. What do you do? Would it make a difference if he currently were your client? So let's take just a moment to think about that. I'm going to take a swallow of tea and clear my throat. And so as we look at the owner of the privilege of confidentiality, it is the client. The client is the holder of that privilege. So if we were to pull up and see someone painting the house, let's say they were a former client, we would wait till they approached us. If they don't approach us, we go on in the house. It's not an issue. That client had a history of assault or aggressive issues or was angry with you when they're in treatment, that could be a different issue. I would encourage you to seek out your clinical or administrative supervisor around that. If that were currently a client, then, that's a little more of an issue. Again, not approaching that client, waiting till they approach you, not divulging that that client is under your care to their, let's say they're with a team or a crew of guys or gals that are painting, then you wouldn't want to divulge that to or breach that confidentiality to anybody on their team or to that team leader. So again, recognizing the holder of the privilege of confidentiality is the client and allowing them to come forth. Now then, when you are back at work and the client is there, you might approach them and say, I noticed that you were on a team that was painting my house. Are you comfortable with that? Or if you're not comfortable with that as the counselor, then you might have to talk with him about not painting your house, and perhaps him letting his supervisor know that he doesn't want to paint that house, and he doesn't have to divulge why or anything like that. But again, just recognizing how to support the client to resolve that. And so the next case study has to do with current clients that you see out in the community who may be, let's say if they were substance abuse clients, if they were imbibing and using a substance, and they are attending an abstinence-based program. So you go out with your friends to Papa's and Beer after work. You're having a beer and nachos when you look up and see a current substance abuse client tossing down a few cold ones in the next booth. What do? And so I'll give you a moment just to think about that. So what would you do? And hopefully nothing, because you're not in a professional role with that client in that restaurant. You're in a personal role. He is the holder of the privilege of confidentiality, and so recognizing that if you were to talk with him about that, it would need to be back in the professional setting and not in that restaurant setting, which would breach his confidentiality that he is guaranteed for treatment. So the other issue is, we'll talk more about that in a moment. Here in Asheville, certainly a lot of folks consume kombucha or buchi beers. They're liquids, drinks that are fermented, but have a very, very low, if any, alcohol content, depending on how long they're fermented. That burns up all that sugar. And they can be drinking those because they look like a dark brown beer bottle. So again, I'll never forget one live workshop that I was teaching, and we brought that up. A gentleman said, we were actually at Papa's and Beer, and he said on a Friday night, the line's pretty long. They were allowing us to go in and get a beverage, and so they were serving us beverages. It was very hot. It was summertime. And he said, I was standing in line. My wife was having a beer. I'm in recovery. I was not having a beer. And I was having I forgot what he said, a Coke or something. And so his wife said, hold my beer. I'm going to the bathroom. And so he was holding the beer when he was seen by someone else who reported him to the agency that they had seen him drinking beer. And in actuality, he was holding his wife's beer so she could go to the bathroom. So again, we can think, oh, we know what's going on, but it can be very non-innocuous. So really checking that out with the individual, especially when it's a coworker, a situation that you don't want to get blown out of proportion. All right, so moving right along. Your coworker that helps with the SAIOP, Substance Abuse Intensive Outpatient, from time to time is reporting about their years of sobriety to the group and how he got sober. A week later, you see him out at a bar drinking what appears to be a beer. What do? So many agencies have in place policies that support counselors and social workers not to divulge their recovery status. And it's for this reason. It can distract from client's care, their substance abuse treatment, and it doesn't become such an issue if a counselor reports sobriety and then they're in practicing a harm reduction model. So again, not divulging their recovery or sobriety status in group can be a policy. But again, just being careful and being aware that what you see may not be actually what's happening, and being sure to check that out with a coworker if you hear them reporting recovery to clients and then you see them out possibly consuming alcoholic beverages, because we don't want to affect the care of those clients out in the community in a way that's detrimental. Another caseworker, a coworker, peer support specialist confides in you that she has started seeing a client that is actively on her caseload. What to do? You don't want to see her lose her job. She's great with clients and is very helpful. And so again, just really defining this, what does seeing a client mean? Because peer support specialists have a little bit more relaxed ethics. and boundaries than the master's level clinician or certified substance abuse counselor or other certifications, because the role of the peer support specialist is to support the peer, to be in the community, to be actively involved in attending meetings and supporting their clients that they're working with, and to really, again, define what they mean by seeing. They could mean seeing could be going out for coffee at Starbucks, could be attending AA or NA or Smart Recovery with them. So we need to understand, does seeing mean having an intimate relationship? And if that is what it means, then to talk with them that that would not be appropriate, that is an ethical violation, and that they would need to cease and desist immediately, not see that client anymore on an intimate basis. And in fact, if they had been seeing that client on an intimate basis, that client would need to be changed to another caseload, under someone else's caseload. So again, just making sure clinical supervision is supporting and helping you with that, and holding that person, peer support specialist, accountable if indeed they had violated ethics and were seeing a client intimately. All right, so I'm hopeful that some of these case studies are helpful in really fleshing out healthy boundaries, and some of the most commonly reported violations actually do have to do with relationships. So I'm hoping to cover both mental health as well as substance abuse case studies. This next case study is actually about supervision. A woman and a man are dating. Both are counselors. One counselor specializes in a therapy that she can supervise the other counselor to achieve their certification. Her boyfriend is seeking that certification, and she tells him that she can supervise him for that. It is a mostly platonic relationship, but they still are dating. Is this an ethical decision? What are possible consequences? So again, really just exploring this with the individual. Anytime there is the possibility of a dual relationship, that's where you're personally involved as well as professionally, it is not a good idea. And why is it not a good idea? Because personal feelings and relationship, if they go bad, if they go wrong, if they go south, then what happens is the professional relationship suddenly comes into jeopardy. There can be biases, personal biases that flow into the professional relationship. So again, just to keep things clean, just to keep things on the up and up, to support not abusing the power in the relationship, it is hugely important to keep those relationships separate, personal and professional, keep them clean. And again, the consequences are, what if that person, if they break up or they have a disagreement, and then all of a sudden that supervision is awash? And then an individual says, I really shouldn't have been supervising you. I didn't document it. You're going to have to go get those hours somewhere else. And especially if they were hours that they paid that person for, then they've lost that money. They've lost all of that. And that's just, again, ill will and ill feelings can result pretty quickly. So another case study, I think we have one or two others, and then we'll move forward. A wilderness program for teens is using timeout to address non-compliant behaviors by placing students ages 13 to 17 in a 4x4-foot square on the forest floor away from other students. So key statement here, key words, non-compliant behaviors. So this is how they're addressing behaviors that are non-compliant. The individuals, the students, only come out of the square to use the bathroom and to sleep. They must eat their meals and do their work or studies while in the square. This can last up to 3 days. You're a new counselor and this seems harsh to you. You are assured by staff that this is both effective in changing the child's behavior and ethical. What steps do you take to explore or let me back up. What steps do you take to explore whether or not this is ethical and legal? So here you are, you're brand new, you've got not a good feeling about the way this child's non-compliant behavior is being addressed. You feel it's too restrictive. You're told by your supervisor or your administration and fellow counselors, this is what happens in wilderness therapy. We tear them down, we build them back, and you're not feeling like this is appropriate because everything you know from the research you've read, from the experience you have, is that this is not appropriate for these children. So you got to go outside the agency. You can either comply and your license is liable, because if you know about neglect or abuse, if this is considered neglect or abuse and is deemed inappropriate, your license is at stake. You are liable for having that knowledge and not acting on it for that child. So I would encourage you to talk to coworkers, previous coworkers. I mean, you've got to de-identify the information. You want to be careful with that. You might want to contact the licensure or certification board. You might want talk with their ethics advisor. You might want to contact, again, your MCO, Management Care Organization. You want to talk to those governing and licensing boards that can help you figure this out. Because sometimes people don't understand that what they're doing is possibly unethical and or illegal. So really advocate for yourself, advocate for that client, and get out there and talk with individuals to gather the information you need to make a decision about how to address and report this. And then possibly you can say to the folks, hey, I've talked with the American Counseling Association or NASW ethics advisor, and they say this is unethical and that I am to report it. Not only unethical, but possibly illegal. It could be neglectful or abusive, and I must report that to the Department of Social Services. And so if you let them know up front and they don't change it, then you've got the steps that you need to take. If they change it, then there's not a need to report it. So again, really taking the appropriate steps to explore, investigate, and get the support that you need to make a good decision to protect the client and your own certification and licensure. Let's look at a case study and apply some of the information we've learned about ethics to actual situations that you might encounter. This isn't the first case study, but a case study involves an agency that has bought an old 2-story house with a large front porch that sits downtown right on the sidewalk in a major thoroughfare. In other words, it's not confidential. It's a beautiful day and the counselor says, let's go outside on the porch for group therapy today. And everyone jumps up in the group except for, 2 or 3 members. So as you notice that and you think about that case scenario, is this ethical and how might it be resolved? Now let's offer a side note that the going out on the porch allows the counselor and the clients to smoke. So there might be another motive for going outside other than fresh air and sunshine and just being out of doors. This particular counselor allowed clients to smoke during group. And that brings some of its own issues up, which we may or may not get into before the end of the video today. So let's kind of break this down a little bit. So what would be the ethics involved? Obviously, confidentiality. Another is relationship between counselor and client. If the counselor's motivation was to go outside to smoke, that would not be appropriate for that particular environment or situation. Often, it's really important that the group is able to focus on what's being discussed, whether it's process or content. And smoking often is a distractor and is a self-medicator, which if someone's smoking, their chances are they may not be talking or focusing on the issues at hand. So looking at this is the key words here is a sidewalk on a major thoroughfare. So if there's people driving up and down the road or walking up and down the sidewalk and they look and see people on the front porch, they might also see a sign that indicates that is an agency that treats addiction, so that would breach confidentiality. The other possibility is someone walking down the sidewalk, seeing someone they knew there and saying hello or stopping to say hi or talk, which would certainly be disruptive to the group therapy. So I think confidentiality is the biggest piece here, as well as the relationship between counselor and client, and keeping that clean, keeping that transparent. And obviously smoking during group would not be supportive of the group process or recovery. Some of the research that we've looked at now indicates that people who quit smoking in early recovery are much more likely to stay in recovery. And so being knowledgeable about and adhering to research around that would be important about not smoking in group for other reasons other than it being a distraction. It can actually be not supportive of the therapy process or a person's recovery. So picking up with ethical and legal perspectives. Under ethical, we're going to exercise control to the highest ethical standards of the profession. And what that means is that when it comes to an ethical issue, we want to really be aware that we want to be as ethical as possible. We don't want to be minimally ethical. I'm trying to think of an example. Perhaps an ethical standard might be if you were out at a restaurant with your family and you saw a client or patient there. And you might say to your family, I want to sit somewhere else. And if someone in the family said, why mom or why dad, why do you want to sit somewhere else? You don't want to say, well, I have a client sitting right over there, or indicate the client in any way to maintain that confidentiality. You might say, I feel it would just be better if we sat somewhere else, and that you followed through with that. Also, again, that highest ethical standard would be maintaining confidentiality at all costs. And then also recognizing that you want to let clients of your or patients that you've worked with know that if I see you in the community, I will not approach you. I want to maintain your confidentiality and your anonymity. And so if you approach me, I will respond to you, but I won't approach you first. And it's not that I'm ignoring you. I want to maintain confidentiality. So saying these things up front to a client can also help them understand. We want to exercise to the highest ethical standard. If in the restaurant you said, well, that person over there is just a client of mine, and you didn't give any identifying information, that would still be a breach of confidentiality and wouldn't be the highest ethical response. So let's move on to legal now. So legal exercise minimal control just above the level of acceptable practice in the profession. So when it comes to legal, it's a little bit different in the way of looking at this standard, in that when you are maintaining a legal precedent, it's really important for a person to be able to meet the most minimal legal standard. In other words, with legality, there's not a lot of gray like there is with ethics. With ethics, there's a gray area of ethics. Again, that minimum and maximum response to ethical considerations. With legal, it's either legal or it's not. It's very clearly black and white. Of course, many cases are argued, and there does appear in the legal world to be some gray area, but there truly isn't when you're sitting before a judge if you have not exercised the highest legal standard of acceptable practice. So a situation might be, we don't have a Tarasoff rule in North Carolina, but we must show that we have done our best to warn anyone who might be harmed by a particular client that you had. So if you had a client that was, let's say, had a history of domestic violence and had abused or injured his wife and or children previously, and you had that client in your office and he talks about in some way harming them or getting back at his wife for divorce or removing or not allowing him to see the children or something, and he talked about having a desire and a plan, and he has let you know that he at some point is going to really show her or be vindictive in some way, then it is important that that you check that out with him for sure and talk with him about that and the consequences of that and about what his motivation is and how help him resolve that motivation and work through his own issues. But if he does not retract and still moves forward on his desire to harm his ex-wife or the children, then it is really important that you notify or talk with the DA, the district attorney, and or the police immediately, and the police then would check in with their supervisors and or a DA district attorney concerning that. If that person did harm, if that man did harm his wife and or children, and it was discovered that you had that information ahead of time and did not act upon it, then you would be legally liable for that. So when it comes to confidentiality, it's really important to remember that, one, what's the need to know basis? And if the need to know is to prevent harm, then contacting and getting help immediately from the authorities is important. And to recognize that it is central to ethics and the legal precedent that we prevent harm. And so really pursuing getting the support you need, both in clinical supervision and from legal authorities, is very, very important. So moving on now, we'll go to the acid test for ethical dilemmas. And so many people often will say, what are some questions I can ask myself when I'm facing a legal or ethical dilemma? How do I kind of sort that out in my head? How do I begin to figure that out? And first, you want to ask, is it legal? Is what's happening legal? So at one time, as I served on a particular board that was a credentialing board, we came to discover that someone, a counselor, had been sexually involved with a client, and that the client's teenage children had become concerned about it and reported it. And right away, we said, is it legal? And so we, as a credentialing board, had to contact our attorney, follow through with that. And if it is legal because it is two consenting adults, that's one issue. It passes the litmus test of is it legal? But then came the ethical piece. Is it ethical for a counselor, social worker, therapist to have sex with a client? And it is not. It is highly unethical. So it may not pass the legal test, but it can, the ethical piece needs to be involved. Another question to ask, is it fair? Is it fair to the client? The client or patient is always first. We want to do no harm, to support them, to grow and learn and change, and have the safety to do that in a confidential environment that is non-judgmental and certainly does not have any blurred boundaries. The next is, how do I feel about it myself? And I think this is probably one of the most important pieces of the acid test, or trying to figure out what is an ethical dilemma and what is not. I often say to supervisees and people that I work with, if it's keeping you up at night and it's on your mind, something that's happened at work or with a client or any area of your professional practice, then chances are there's some ethical issues involved, because what keeps us up are thoughts and feelings of the situation being unfair or judgmental or manipulative, or that there may be harm about to be done. So I encourage you again to check in with yourself. How do I feel about it myself? And again, if you can't sleep at night, talk with your clinical supervisor, talk with your coworkers, And if it's more of a legal issue, then you can talk with the Department of Social Services if it involves child or adult abuse or neglect. When you talk with social services, you don't have to make a report. You can simply call to gather information and to get a consultation about that situation. And I must say that doing that may give you varying responses from various county Department of Social Services. Some of them can be more helpful than others. I just encourage you not to stop gathering information until you're able to really assist and support the client or patient. The next is, have I checked it out with someone I trust and who has also strong ethical and moral values? And so we all, regardless of how long we've been in the profession, have professionals around us that work in our agency or other agencies. We have people in the community who are clinical supervisors. It is not uncommon for people to contact me as a clinical supervisor to say, I'm in an agency and I've taken this ethical or legal concern to my supervisor and I'm not quite comfortable what he or she has shared with me. Could I set some time up to come consult with you, or could you refer me to another clinical supervisor so I can sort this out? And again, going to someone that you trust, that has that history of strong supervision, and or someone that you believe has good, strong ethical and moral values. I think sometimes when we work in an agency where we may not be feeling that we're getting the best support that we need, both administrative and clinically and supervision, that we may hesitate to ask for help or to staff a case or to talk with someone about an issue. So once again, I encourage you to call and talk with other professionals. Be sure to de-identify the client or patient so that there isn't a breach of confidentiality there. The other resource is if you're a member of the American Counseling Association or National Association of Social Workers, they often will have ethics counselors or attorneys, and they will set you up with a phone consultation with either one or both after your situation is screened, and they can support you around that. So that's a great resource and a good reason to join American Counseling Association and or the National Association of Social Workers. All right, moving on from that acid test for ethical dilemmas to ethical decision making. So here are some more questions to utilize when you're trying to make a decision about whether or not what is happening between you and a client, or between a client and another counselor or the agency, or perhaps even a referral source, if it's ethical or not. The first is, whose interests are involved? So when we ask that question, again, like the two-story house with the counselor and the clients going outside to smoke, we can see that someone's interests may have been involved other than just the client's. Perhaps the counselor was wanting to smoke, and it's not about the counselor. The counselor needs to hold that ethical standard. And so whose interests are involved? Is it just the clients? Is it the counselor? Is it people in the agency? I'm hearing more and more from various counselors and social workers who work for for-profit agencies, and they feel that there is some jaded decision-making happening in supervision because of the connection between the for-profit agency and pressuring counselors to see more clients than they're able to see without rest or pause throughout the day, running groups of numbers that might be a larger number than is acceptable to Medicaid or the managed care organization. So when there's actual policy breaches within an agency, there are more interests involved than just the counselor and the client. It can be agency, it can be the managed care organization, it can be the state of North Carolina's Department of Health and Human Resources. So what are the interests involved and how do they play into what you're seeing or experiencing as a possible legal or ethical dilemma? And this segues straight into who can be harmed. So who might be harmed if you don't speak up or hold that boundary or get more information so you can understand about what's truly happening in this situation? And if who is being possibly harmed, do they have a voice? Because many of our clients don't have a voice. They don't know who to report ethical or legal violations to. They don't know who to ask for help. They don't know sometimes what healthy boundaries are. Especially in active addiction or with personality disorders, they have experienced life with few or no boundaries. And so when they step into being in a relationship with a counselor and an agency and or other group members, they're not aware of what often appropriate boundaries are. So who can be harmed and do they have a voice? And it is very important for us to help those who can be harmed to have a voice and to explain to them what their rights are and who they can report their concerns to. If they have concerns about a counselor and they're licensed by the North Carolina License and Professional Counseling Board, then giving them that number or giving them access to that to report that. Of course, with clients, it's really important if they feel safe for them to approach that counselor first to talk about what they're struggling with or their concerns. If it was a social worker, then it would be with the North Carolina Board for Social Workers. So again, who can be harmed and do they have a voice, and helping them have a voice to speak their truth and to take care of themselves. Another is what universal values apply. And those universal values are many. The right to confidentiality, the right to be respected, the right not to be punished or shamed during treatment, the right to speak up and have a voice, the right to have fair payment, that not to be charged not to be charged more than what they are able to pay, and especially if they're an agency where there is a sliding fee scale or Medicaid. I know in years past there have been DWI programs that charge some clients more than others. And that was based sometimes on how they felt the clients, more wealthy clients, could pay more, and that was highly unethical and inappropriate. So again, universal values apply of equality, another one. So as you move forward in exploring ethics and seeing and experiencing ethical violations, really noticing what are the universal values that apply. Are there values in conflict? Again, the agency's policies, if they're in conflict with the managed care organization, then it would be important to talk with your clinical and or administrative supervisor about that, versus staying quiet. There was a policy years ago where it was mandated by the managed care organization that a client could only have so many hours of SAIOP per year. And many clients, of course, had relapsed, gone into treatment, come out, and they were ready to start SAIOP again as a step down. And what we discovered is, though there wasn't funding for that SAIOP, the SAIOP step down was actually required as a step down in the level of care. And so when we discovered that the policy of our agency and the state guidelines did not match the managed care organization, we had to take that to the managed care organization, and they did correct that immediately and provided the funding for that step down. So I think it's really important to realize as counselors, we do have a voice. When we see, again, values in conflict of policy and or procedures from the various levels, from your agency to the MCO, to the state, to the federal government and Medicaid or Medicare or another payment source, is that if you see discrepancies or incongruencies, that you talk with clinical or administrative supervision and talk with them about that and get that resolved. Because in all in that particular situation, we helped many people to step back into SAIOP and get clean, and from that continued service, that continuum of service. So moving on to what ethical or legal standards apply. So when it comes to ethical and legal standards, it's really important that you look at your licensure board, if you're an LCAS or a CSAC or another license by North Carolina Substance Abuse Professional Practice Board. You want to pull their ethics up, their online ethics, through their website, and read those and think about those and learn those and integrate those into your practice. And then if you're an LPC, that would be the National Board of Certified Counselors, and pulling their ethics up and beginning to read about those and learning those. And most ethics are by topic, such as counselor-client relationship, and then it might move on to other standards of care, such as matching a level of care with the appropriate treatment level. Let's see, I'm drawing a blank. Supervisory ethics between the supervisee and the supervisor. So as you look at those various topics, it's very helpful to learn, kind of chunk it, because there's so much to learn and so much to remember that looking at the topic and how it actually applies to various relationships and areas. There's one for education, ethics in education, such as online or face-to-face. So again, really looking at those topic areas. It's also helpful if you know specifically what your ethical violation might be, then you can go directly to your licensure board website and surf down and find the topic area, and that might help you gather information and make a decision more quickly. So what ethical or legal standards apply? When it comes to legality, I would recommend that if you're in an agency, that you contact your clinical or administrative supervisor with your concern. If they have questions about it, the legality, they would talk with the attorney that is on retainer for that particular agency. And if that doesn't work or there's concerns there, then your supervisor and or you can contact the North Carolina Department of Health and Human Services, and they would direct you. So I think the main thing I want to really emphasize here is don't give up. If you truly know, believe, see, and experience and are being kept awake at night by an ethical or legal dilemma, gather information and keep asking until you feel like you have gotten the answers that you need to protect that client or patient. And now moving forward with the spirit of ethical decision making and behavior. We want to first do no harm, and that means not only the client, but anybody that the client or patient interacts with, because do no harm is not just about the client. If the client is verbalizing possible abuse or neglect that they're currently involved in or wanting to do to someone, that harm would also involve other people in the community. So do no harm is not just about the client or patient, it's about who the client or patient might be interacting with. I'll give you an example. Being aware that the state of North Carolina does not allow the abuse or neglect of a caregiver of children. So if you have 2 or 3 people that are living in a household and one of them is neglecting or abusing the other caregiver, then it's believed that that caregiver cannot properly take care of that child or children. And so that's really important to know and check out with the Department of Social Services. That's one that most counselors and social workers are not aware of, but it's really important that a parent that's actively using substances or violent in the home, that's abusing another caregiver, he or she cannot adequately take care of those children, much less be emotionally available to those children. Do support the benefit of the client. And so when a client is telling you many things about what's happening in their life, we want to support them. We want to not jump to a conclusion where if a client is saying something about, let's say in a teenager, this is a classic example, that a teenager might say, my dad pushes me around, he hollers at me, he screams at me. And so when someone says that, that might sound a little bit like, or a lot like, child abuse. And so we want to talk with them about that, to say, tell me more about that. When did that last happen? When you say your dad pushes you around, tell me what that means. What does that look like? Because pushes them around could be verbal, telling them they have to clean their room, they can't drive the car because they smelled like beer when they came home last night, or something of that nature. So we want to be careful that we support the benefit of the client, to understand and explore with them what's happening, but not collude with the client against other people in their lives if there's a question about that the client may be manipulative or trying to get the counselor to collude with them about how awful someone else is. So supporting the benefit of the client, just being careful with that and really explorative with that. Do set down an example that rises above all. And what that means, we're getting really into that area of the spirit of ethics. Not just ethics, I've got to do the next right thing, but the spirit of ethics. Why do we maintain confidentiality? And we do maintain confidentiality because it supports the client-patient relationship with a counselor or social worker, so that the client can feel safe to do their work. They can feel safe that we've created a container of safety and presence with them that's absolutely confidential. Caring for them, open to them, non-judgmental. It's just, we want to set down an example that truly embraces the spirit of that ethic, that ethical value. Why do we truly value confidentiality? Because we as a person, if we as a counselor, went to therapy, we would want that confidentiality. We want somebody to value our lives enough to not share our most personal struggles with someone else. That's such a violation if we share something that creates such vulnerability in a desire to grow and learn and change, and we found out that was shared with someone else. So do set down an example that rises above by honoring the spirit of the ethic. So do seek to grow in your own right as a professional. So again, there's the ethical consideration that you have the right to grow and learn yourself, that you're going to make mistakes. I've made mistakes. We all will when it comes to being in a relationship, a therapeutic relationship with clients and patients. And we want to really, we want to learn from our mistakes. We want to take responsibility of our mistakes with clients and patients. And when we do that, we're setting an example, showing them that you can make a mistake and grow and learn from it. Years ago I made a mistake with a client, he had asked me, I wish I had a dime for every time someone's asked me about my own recovery. And that particular agency did not allow the staff to share with patients or clients about their own recovery status. And I remember saying to him, I have really suffered throughout my life, and just shared a little bit about the loss of my parents, and a particular parent to suicide, and a couple of other details like that were out of my past. And I'll never forget him looking at me, and he said, you know, you're right. What I did need to know, and I didn't need to know anything about your life, I needed to know if you had suffered. And I said, thank you for bringing that to my attention, and I'm sorry that I distracted you from what you were really wanting and needing to know. And yes, I have suffered, and I haven't met a human being that hasn't. Have I suffered like you? I don't know that because I don't know what your life is like. But I am here for you and am supportive of you to grow and learn and heal from your addiction and the many hurtful relationships that you've experienced. So do seek to grow in your own right as a professional, allowing for mistakes and learning from them and taking responsibility for those. And when I think about growing as a professional as well, it also means don't get bored with the therapy that you're doing, the counseling techniques and the curriculum. If you're stuck in CBT land, cognitive behavioral therapy land, I call it, and you've been using the same curriculum, perhaps matrix over and over and over, and you're bored with it and it's not fresh anymore, it doesn't feel alive, then grow in your own right by getting online and exploring curriculum that creates newness and freshness. And a good example of that is over the last few years, mindfulness has become a core component of both mental health and substance abuse treatment and curriculum. And so getting online and incorporating mindfulness with the CBT. The new wave of CBT is mindfulness infused. So when you think about growing, there's many ways to grow as a professional. And it would be highly unethical to stay with the same curriculum that you're bored with, and your clients notice how bored you are, and they drop out of treatment because they find you're boring and the curriculum is boring. So again, ethics is another area where you can really apply it in many, many areas. Do give back with pro bono services if that's allowed in your agency. And if you're in a private practice, recognizing that pro bono service where you're offering services gratis or for a very small fee, that it can be a way of reaching out to many people who otherwise could not afford therapy. And the last one, and this is a quote by David Powell, who we call him the father of clinical supervision in substance abuse counseling, but he also, it applies to dual diagnosis as well. He says, do sit in the stillness, feeling and knowing the spirit of all goodness and healing has brought you to this dilemma, to this place, to this ethical decision making. So if you're in a place where you're really struggling with ethical or legal concerns, sit quietly, meditate, be mindful, gather information, and make a decision that protects the client and you as well. So ask for help and don't give up. So moving on to the codes of ethics and the categories, that's what I referred to earlier, that if you go to the NBCC website, ACA website, American Counseling Association, or the National Board of Certified Counselors. If you go to NASW, National Association of Social Workers website, you'll find the Code of Ethics, and they're broken down into categories, which will help you, if you're in a dilemma, find where you might begin your research or exploration. So the first is purpose and scope. So what's the purpose of the ethics and what's the scope? What does it include? Ethics in the counseling relationship. Confidentiality, privileged communication, and privacy. That privileged communication gets into that need-to-know basis, and we'll get into that if you are on an ACT team and you are the therapist on an ACT team. If the client shared something with you that is only what you need to know as a therapist and not what the vocational counselor needs to know, then you wouldn't share that with a vocational counselor. Again, that's need to know. So moving on to counselor supervision, training, and teaching, which covers actually what we're doing here right now. Insofar as training and teaching, supervision would be the ethics around you and your supervisor. Professional responsibility is, again, a topic that covers many areas, and we'll get into that in a moment. Relationships with other professionals. And one of the classic examples is doing group therapy with another professional. And we'll talk about some ethics in that. Evaluation, assessment, and interpretation. So that talks about your assessment that you do with clients and any type of evaluations, such as running a back and depression inventory or something like that. And we'll get more into that in a few moments. Research and publication. So when you begin to do research and or publish, there are specific ethical guidelines. And resolving issues. When there is an ethical or legal dilemma, we encourage you to take it first to that person that is involved in that. But we'll cover that more in a moment. So that resolving issues is referring to how to resolve ethical dilemmas with the person that the ethical dilemma is concerning. So purpose and scope. Ethics involve the recognition of diversity, embracing a cross-cultural approach in support of the worth, dignity, potential, and uniqueness of people within their social and cultural contexts. And why is this important? Because as we move from doing therapy or counseling or social work in various cultures, such as near here in Western North Carolina, we have several different cultural groups. One being very obvious is the Cherokee culture here and population near the reservation in Western North Carolina. Another might be the mountain culture. Some of the culture here in the mountain is very specific to the population that has been here for centuries and some of their cultural beliefs and that type of thing. And another is just recognizing the worth and dignity and the potential of each human being to heal. It's not uncommon to hear someone say, well, that addict, he or she's not done using yet. They're not going to learn. They're not going to respond to any treatment. And making those kind of blanket statements doesn't recognize the dignity and potential and uniqueness of that person. And so remembering that when it comes to a person in recovering from a disease, whether it's mental illness or substance abuse, it often takes many treatments before they can get enough clean time to heal. Remembering 3 statistics. 1, the older a person gets, the more likely they are to stay in recovery. The more treatment that they get, the more likely they are to stay in recovery. And the more clean time and compliance with their medication regimen indicates that they're more likely to stay stable and in recovery. So when we know that, it would really behoove us not to be derogatory in any way towards a person who hasn't been able to maintain their recovery from mental illness or substance abuse. So ethics involve the recognition of diversity, embracing that cross-culturally, and supporting the worth and dignity of every human being based on their uniqueness and their cultural context. So moving now to the counseling relationship itself, the primary responsibility is to respect the dignity and to promote the welfare of the client. So the key words here are obviously respecting the dignity of the client. Now, you know and I know sometimes clients come in and they don't act dignified, but just because they don't act dignified doesn't mean we don't hold the standard, the ethical standard of showing them respect and treating them with dignity. Hugely important, even in the face of them really being angry, being high, having substances on board in their system, screaming, acting beyond anything sometimes what we even could imagine. And specifically when there's personality disorder involved, it can be very difficult to sometimes to respond with respect and dignity. But that is the ethical standard, and when we model that, it lets them see, feel, experience, and know that there are other ways for human beings to care and to respond. And remembering that 99.9 times out of 10, when clients or patients are acting out, they're coming from a place of trauma or in childhood or adult. And because they haven't been respected and haven't been treated with dignity growing up or as an adult, they don't have a reference point. And we may be offering them the first unconditional regard. And this is hugely important in building trust and rapport in the counseling relationship. Another example is everything we say and do impacts the counseling relationship. When you're about to do an assessment, and assessments, what we call the CCAs, the clinical assessment, can be quite long now, hour and a half, sometimes longer. Do we ask them, would you like to use the restroom or get some water before we start? The assessment takes about an hour or an hour and a half. That communicates caring. If a person is unable to sit still for that whole assessment, do we give them a break and allow them to go to the restroom? Now, supporting them to go outside and smoke a cigarette is another thing. Some of you may want to allow for that if that client is becoming agitated or really struggling with questions in the assessment. I'm not saying don't allow them to smoke, but it shouldn't be that they're doing fine in the assessment, they're just wanting to smoke just to take a break, when that may or may not be what's appropriate at the time. So other ways to respect the client is being sure they know and understand their patient rights and client rights. Many times I've supervised people, and when they have that whole packet for the client that they're registering them, gathering information, or even at the front desk, they might put forth the client rights sheet and say, these are your client rights, sign here, without reading them to them, without discussing them, without them reading them. And some clients will want to sign that without reading it. And that's completely inappropriate, because really the client's rights, when they sign that, that's part of the informed consent, that they know what their rights are. So those rights dictate the counselor-client relationship. So we could go into many, many more examples, but the counseling relationship is one based on mutual respect and rapport, and really being sure to make that connection is hugely important. Defining the counseling relationship. So as we look at areas to look at when it comes to ethics is record keeping. Many people will not, an example might be when they're making a note, a clinical note about a client. Let's say they've experienced a disagreement with a family member. The counselor won't put that family member's name in there. They might just say their wife or husband or child, rather than recognizing that that family member also has the right to confidentiality. And to put them, their name in the record may not be appropriate. So recognizing that there's ethics that cover records. Treatment planning, an ethic that would apply to treatment planning is supporting it to be client-centered and client prioritized. So when you've identified with the client their problems and you're creating a treatment plan, it's really important to make sure that that client is agreeing to that treatment plan, and it's created mutually by you and the client. But the client has the last say-so. If they say, I'm not ready to quit smoking, then why put it in their treatment plan? If you think it's important for them to quit smoking because they, let's say, have emphysema, you know, medically that would be sound, but the treatment plan is what the client is agreeing to work on. And if they have emphysema and they're dying from it and they don't want to quit smoking, it's starting where the client is at and not putting that in the treatment plan if they don't want it on there. That doesn't mean that you don't share your concern and worry about them smoking if they have emphysema, and or referring them to back to their doctor around that. Perhaps even talking about a smoking cessation pack or something else that would be helpful. Let's say the client is culturally isolated and they don't know about the smoking cessation patches. So again, defining the counseling relationship, utilize client support network, so pulling in friends, family, community stakeholders. Let's say they're homeless and they go to a particular homeless shelter. Is there someone there they're close to that you can pull in to support that client? It would be unethical not to determine their client support network and assist them in utilizing that. Informed consent, we spoke about. It's not informed if they sign papers that consent to treatment and they have not read them or understand them. So informed consent means they have been informed and they understand it. Really also being careful that if you're asking someone to consent to care, if they don't read, and making sure that every person can read and understand what's before them. Avoiding physical and emotional harm. No romantic or sexual relationships for 5 years. So depending on whether you're a counselor, social worker, or what your licensure board is, some licensure boards say no sexual relationships with the client ever, and some say 5 years. So that's important to know what your licensure board advocates and to follow the most restrictive licensure board. If you're a social worker and you're licensed by NASW or the state board, and you're also an LCAS, you would follow the ethical standard of the most restrictive, of the board that has the most restrictive ethical standard. Advocacy for the client, really advocating for the client to get the services they need, to get transportation, to knock down those barriers that prevent them from getting the treatment they need or their family members. Confidentiality, we've discussed. Again, remembering the key piece here is not only what is kept confidential and the importance around that, it's also key to remember about informing a client if there is neglect or abuse, then I need help to be able to help you, and that is reportable to the Department of Social Services. Remembering do no harm. If there's a client that's verbalizing that they want to hurt someone in their family or the community, is to talk with them about that and then as appropriately notify the district attorney and or the police or county authorities, such as the Sheriff's Department. So confidentiality, the other piece is that need to know basis. It doesn't mean that if someone is going to an agency that everybody at that agency has the right to their information. Confidentiality in an agency is based on a person's job at the agency in relation to the client. Do they need to know to be able to carry out their job? And if they don't, it should not be shared. Screening and protecting clients. Again, I think often of group work, such as substance abuse intensive outpatient or dual diagnosis group. Any types of group, grief counseling, other groups, is screening and protecting clients. If that client isn't ready to be in group, they have poor boundaries, then chances are they're not going to maintain the group's confidentiality and anonymity. And so screening those clients out ahead of time until they stabilize is very, very important. Having in-group guidelines, confidentiality, it's what's said here stays here. Be aware that confidentiality is not guaranteed in this group setting. So don't share if it's something that you are very sensitive about or you believe someone in this group could leak it to someone else who you know. And when it comes to the world of addiction, there's many people who know the people in their group, who are friends with other friends, and it can get out of control pretty quickly and confidentiality is breached. The majority of confidentiality breaches aren't purposeful. People have concern and they're sharing information and they don't recognize how harmful it can be. End-of-life care. So this gets into a whole controversial area we won't get into today, but the right to make decisions about how one lives and dies. Let's say a patient refuses cancer medications and they're dying from cancer, and that physician is really adamant that this cancer medication could save their life, and yet the client still is refusing that medication. This also gets into parents who have specific religious affiliations that don't allow medications to be given to themselves or their family members. So again, that end-of-life care, medical care, is important to really watch closely and get supervision as needed. Refer out if there is a bias or a conflict of interest. Let's say you walk into group one evening and there sits a distant cousin. You haven't seen them in years, but they're a blood relative and you grew up with them, you know their history, you share family members in common. It would be important to go and talk immediately or contact your supervisor about the situation, and the two of you make a decision about whether that person leaves immediately or stays in group and doesn't participate. But the owner of the privilege of confidentiality and the care of the client is the client themselves. So just be sure to, if there's a conflict of interest, to refer out. Establishing fees and dealing with non-payment and bartering. Again, some folks have sliding fee scales, and some insurance companies don't like that and will not allow for that if you're if you're credentialed or approved by that insurance company. So that's another area to watch for. So as you establish your fees, being upfront about those, how that's determined, and dealing with non-payment. The next is technology applications. I might go back to establishing fees and dealing with non-payment and that type of thing. It is not uncommon for people in private practice to keep on file a credit card number because you're seeing the child of a person or an adult under the care of another older adult who is going to pay for that care. It's really important to keep those numbers confidential and safe, and to make sure that once that patient leaves your care or client, that that number is destroyed, and also that you truly do have permission to use that number. For me in my private practice, I often will ask for a consent based on just financially that I would like to call the person who that card belongs to confirm that they indeed are willing to pay for that therapy and what my fee schedule is and that type of thing. That way there's no misunderstanding. So as you can see, there's tons and tons of examples as we go through each one of these, and there's no way we can hit on them all, but I do want to sensitize you to some of the examples that I'm aware of as a supervisor. Technology applications again. If you're filming, if you're an LPCA in particular, it's important that you do audio and or audio video of your sessions that you share with your supervisor. Those need to be erased after the supervisor and you observe them or listen to them, and that you keep that in a locked place safe when you're transporting it. So there's a lot of technology applications because technology is going so fast now. Another technology application is, do you accept texts and emails after 5 o'clock? Do you let your clients or patients know that after 5 o'clock you cannot be reached? If they have an emergency, they need to contact mobile crisis or go to the emergency room. So how much do you allow your technology to be open to clients? Personal cell phone numbers, that type of thing. Because if you have a history of accepting texts after hours and you miss a text and someone was to text you that they can't live anymore and they're going to take your life, and then that was discovered in court, and you can be liable for that text if you had previously accepted texts at all hours. So texting is one of those slippery slopes that we want to really be careful with. Termination and referral of the counseling relationship is, do we notify clients of expected termination dates? Do we refer them out? If someone is a no-show, do we send them a letter that says, you know, we saw that they are no longer attending, and refer them out to other agencies, and then keep a copy of that termination letter? And specifically saying, if I do not hear from you within 5 business days, I'll terminate our relationship, our services will be terminated. Please contact me before that 5 days if you'd like to schedule another appointment. And that often is dropped by many people, especially in agencies where you see so many people. But there are clear ethics around termination and referral. Moving on to confidentiality, privilege, communication, and privacy. Trust is the cornerstone of the counselor relationship. Counselors aspire to earn the trust of the client by creating an ongoing partnership, establishing and upholding appropriate boundaries, and maintaining confidentiality. So we know that. We know it is the cornerstone. It is the core of our relationship. And without that, we don't have a therapeutic relationship. So that's hugely important. It's really important to, again, as we talk with clients, telling them, if I see you in the community, I won't approach you. It will be up to you to approach me. How else do we earn trust? How do we earn the trust of the client? I think listening, being non-judgmental, really being open and aware of how the courage, not how, but the courage that it takes for that client to turn that doorknob to come into therapy, that they are exceedingly vulnerable and exceedingly frightened and sometimes feeling a lot of shame because of what they've been through in their life. And they're very sensitive and pick up on very subtle cues from the counselor or social work. If we're exhausted or stressed or frustrated and we're about to do an assessment and we come in huffing and puffing and not making eye contact and seemingly tense or stressed, that client will pick up on that. And they may internalize that as, oh, they don't like me, or I've said something that I shouldn't have said, something like that. So again, knowing that many clients come in very sensitive in a highly emotional or activated state, and if they don't come in that way, the very questions we ask them in the assessment process can trigger that. And so taking a deep breath, really getting grounded and centered before we step in to do that assessment so that we show up fully with our heart, with our openness, with our kindness, our compassion, and that the client is able to experience that from us, that unconditional regard. Confidentiality, respecting client rights. Again, a client won't know what their rights are if we don't explain them. Some of the exceptions, such as abuse, neglect, or a judge's order for patient records. So we want to recognize and understand that there are exceptions to confidentiality, and that needs to be covered with each and every client and patient. Information shared with others on your team. Again, that need-to-know basis. Confidentiality in groups. Is it guaranteed or not? In talking about that with clients and patients. And if confidentiality is breached, how to handle that, how to salvage that situation. And confidentiality should be talked about at the beginning of every group, along with group rules and guidelines that create that safety in group. Clients lacking capacity for informed consent. Are they mentally ill? Are they currently inebriated or have substances on board and are high and may not be making the best decisions? And so again, the clients lacking the capacity for informed consent, then we would need to ask them if they have someone that's close to them or is supportive of them that could come in with them to give consent for treatment. Or waiting and rescheduling their appointment to when they're not inebriated or high from a substance. So another is confidentiality of records, keeping those records safe under double locks. If you're riding around in a car, your briefcase should be locked. Your briefcase should be locked in a trunk. If your records are in your office, are they locked in a cabinet that's behind another locked door? So basically, most state laws refer to that double lock standard, that records should be locked, double locked. research and training. Again, confidentiality around that, getting true consent for that research, and to utilize all ethics around training. One of the ethical standards is, do we offer a sliding fee scale when it comes to training, or do we offer a scholarship for training, that type of thing. And consultation. A key piece here is confidentiality and consultation. If you're talking with someone who doesn't need to know the identity of the person, but you're trying to gather information and explore an ethical or legal dilemma, is de-identifying that information as you share that information for a consultation and receive information back. So professional responsibility. Counselors actively participate in the world, taking on responsibilities from self to all levels of society that impact the counselor and the counseling profession. So a little bit, keywords are, we are participants in the world. We're not isolated. We take on responsibilities, both for ourselves and all levels of society. And that's going to impact who we are as a counselor and the counseling profession. And again, I think for what really speaks to me here is advocacy. Are we advocating for those without a voice? Do we advocate for the poor? Do we advocate for the abused man or woman who is so beaten down they don't even know how to help themselves? Do we make sure that we can get them to a shelter for safety? Do we, when it comes to children, do we make a choice not to inform DSS because we don't want to alienate those parents, but yet that child has to live with that abuse and neglect every day, and we as counselors go home to a safe, warm house where no one's screaming at us or hitting us? So again, we're part of a world that we take on a lot of responsibility, and I think advocating for ourselves and clients is really, really important. That we stay abreast on the latest research, the latest curriculum that utilizes evidence-based treatment, so that we take part in the world. There are many counselors that I went to master's level in counseling training with, got our masters together, who are now politically active and running for office because they feel like that advocating for their clients, that they have to be politically involved. And there's some boundaries around political involvement and how we do that in relationship to clients and patients and people that we supervise. So again, this professional responsibility, I like to think that if we break down those two words, professional responsibility, is that we choose to embrace the spirit of those two words by responding to life at all levels professionally, where we profess our values in everything that we say and do that emulates a world, our values in a world that isn't always ethical. And, you know, just now in 2018, going into 2019, many policies that are being passed by our government are prejudicial and abusive of our clients because of their economic or social status. And it's really important that we become involved wherever we can to advocate for our clients. Professional responsibility, fleshing that out, boundaries of competence, practice within your scope of practice. If I'm not trained in treating sexual addiction, I'm not treating it because I wouldn't be helpful to the client. I could, if I had a client that had a sexual addiction, I could say, I can't treat you yet, but I'll be glad to treat you in the future. I'm going to get some online training. I'm going to do some case consultation. I'm going to look at curriculum. I'm going to get trained because I have a licensed professional counseling degree. I'm going to broaden my scope and get training in that area, and then I'd be glad to train you. But at this time, it is not within my scope. Advertising and soliciting clients. And so know your board's ethics. Clearly know what your board's ethics are when it comes to how you can solicit or advertise for clients. Professional qualifications and certifications. So what are your qualifications? Are you certified in all the areas that you're treating if it's required by your state? It's important that if you are able to follow through with certifications, specifically like in North Carolina, we have many certifications in marriage and family therapy, substance abuse treatment. I'm trying to think of any others. Emergent care, like crisis mobilization, that type of thing. So it's really important to know what your qualifications are and if you want to pursue certification. Non-discrimination towards all, and that's regardless of race, gender, culture, any areas, any and all areas which patients may identify with, LGBTQIA as well. Non-discrimination towards all. And if you find yourself having a bias or feeling like you are uncomfortable with a particular population, seek out counseling yourself, talk with your supervisor, but I'd encourage you to not treat someone that you may have a bias concerning. And that means blind bias as well, which if it's blind, it's hard to know about it. But that's also why we look at doing workshops in how to notice in areas where we're biased and not. There's a lot of online questionnaires and things now in YouTube videos about uncovering your blind bias. Public responsibility, being responsible to the public professionally. And that means that when I, let's say have a drunken client in a waiting room and I have concerns about other clients in that waiting room, about their safety and his boisterousness, that I take responsibility for that client by contacting the authorities and securing safety in that lobby, in that waiting room. So we are responsible for the public that we come into contact with. Advocacy for clients. And again, picking up where clients often don't know their resources. They can't advocate for themselves because they don't know. If they do know and they're asking for your support and advocacy, then please support them around that and become very active in the community to advocate for client rights. Relationships with other professionals. Counselors are respectful of approaches to counseling different than their own. That means if I'm in a group with someone, another counselor, and we're leading that group together, that we meet before the group starts to talk about each of our responsibilities, what curriculum we're using. We might staff patients or clients that are coming into that group that have been volatile or really struggling or any other dynamics. It would be really important to respect one another by preparing for that group. Relationships with other professionals. Counselors are respectful of approaches to counseling different than their own. That means if you're doing a group with another counselor and they are presenting material more differently than you are or would have, that doesn't mean that they're bad or wrong or aren't doing it right. It means that they may have a different perspective, or the main thing is just to allow for different approaches and to respect other people's counseling styles. I think another piece to remember is that certainly people just coming into the profession that are under supervision often don't have the experience of a more counselor who's been in the profession longer, and to allow for those differences and to allow for those mistakes and for those supervisees to learn from those mistakes. Counselors work to develop and strengthen interdisciplinary relations with colleagues. Again, that you're someone who is being ethical, is supportive of their coworkers. They are open to helping them learn from their mistakes, open to helping them and supporting them to attend trainings. and to apply those materials to the clinical environment. It's really important to understand that without developing a good, strong referral system of varying resources, whether it's food, clothing, housing, other resources, and really getting to know those staff at those other resource referral places is really important so that you can reach out and advocate for clients. So working to develop and strengthen relations, interdisciplinary, as well as community resources and that type of thing. Counselors participate in interdisciplinary teams. And we referred to the ACT and CST teams earlier that are in mental health facilities. All of those teams have counselors, they have nurses. The ACT team has a physician on that team. There's vocational rehab counselors, substance abuse counselors, master's level clinicians. And so recognizing that counselors and social workers participate and play very important roles in an interdisciplinary team. And being sure to advocate for your discipline. If you're a substance abuse counselor and you see a client who's struggling and is perhaps pre-contemplative or have had multiple relapses, and you hear statements from other staff on that team, such as, "Oh, he's not done yet." In other words, done yet using. Or, "He's a drunk and he'll always be a drunk." Statements that are definitive, that label and become barriers to a client receiving the interdisciplinary care that they need is not a good thing. And not really judging that person who's saying those things, because it sounds like when somebody says that, they're burned out, they're bitter, they're struggling themselves, or that they don't understand the biochemical disease model. It's not a moral issue, substance use, abuse, and dependency. It is a biochemical disease model that their brain chooses that drug. And until they're able to get treatment and rally the support they need around them, oftentimes it's very difficult, almost impossible, to heal from the ravages of addiction. And for many people who have been in active addiction for a long time, they're leaving a trail of destruction that takes quite some time to acknowledge and work with and repair. And leading into that, I'm preparing a workshop on the opioid epidemic, as well as a workshop, a training on toxic shame. That's something that I'm seeing much more right now in my practice and working with opiate-dependent clients, is the toxic shame that comes out of that particular addiction. Not that other people can't have toxic shame, but how to actually work with that. And so moving forward to counselors, we said counselors participate in the interdisciplinary teams. Next is counselors alert their employers of inappropriate practices. Again, the example of the group therapy where the counselor is saying, "Who wants to go out on the porch to do group tonight or this afternoon?" And most people stand up except 2 or 3. If that counselor says, "Well, if you don't come with us, you can just go home," that would be terribly inappropriate, unethical, and making sure that if that counselor isn't open to hearing how inappropriate that is and advocating for those clients who are left sitting back in that room, then it would be something that would be appropriate to report to the employer or clinical administrative staff. So counselors can, going back just a minute, picking back up on counselors alert their employers or their administrative staff of inappropriate practices. Some individuals, some counselors and social workers will work in agencies where the ethics are violated. It's going to happen. If that agency does not appropriately address that, then another option is to report that to licensure boards, to report it to the Department of Human Resources, to report it to the Management Care Organization. In this area, it's VIA. So to not stop taking action until that's corrected, if at all possible. And if it comes down to it, finding employment at a different agency to protect yourself. Because certainly where there's ethical violations, that can lead to legal violations. And if you're part of that in an agency, you can be implicated. So it's really important to recognize your values and your ethics and make choices in employment that emulate your values, both personal and professional. And last is counselors consult within their expertise. So if, again, if someone on your ACT team or CST team ask you about substance abuse and about doing a substance abuse assessment, and that's not within your scope of practice, it would be really important for you not to do that part of the assessment because you would not get an accurate assessment, thus the treatment would not match the needs of the client. So again, that's just, that an example of consulting within your expertise or sharing information that is within your knowledge base. Next is evaluation, assessment, and interpretation. Counselors use assessment instruments as one component of the counseling process. So in other words, when a person comes in, one of the first things that you're going to do is welcome them to the agency, help them get comfortable, know where the bathroom is, some water if you have that available for that client, because often an assessment can take up to an hour and a half, and in some programs up to 2 hours. So you're going to know and be comfortable with your assessment instrument and recognizing it is one component of the counseling process. And again, I like to encourage people to be trained in motivational interviewing and enhancement counseling, because therapy begins with the assessment. And if we can, during the assessment, help motivate and inspire and move folks from pre-contemplative to contemplative in their understanding of where they are in their mental health treatment or substance abuse treatment, that's really important, because the assessment is not for the counselor. The assessment is for both the counselor and the client to assess where that client is at and to identify appropriate needs and to develop a treatment plan mutually. So being a component means it's not a begin and end all. So we're going to take into account the client's personal and cultural context, where they're coming from. The person sitting in front of us may be pretty contemplative about their addiction to alcohol because their mother has said to them growing up, you'll always be a drunk just like your daddy. And that person may be fulfilling that statement by their mother. And they really don't have belief in themselves. Until we do an assessment, we talk with them, we explore with them. And if that came up, we can say, I don't believe that. Within every individual is the capacity to heal and to get sober. And that may be the first time that person has said that. So what we may see in front of us is an angry person who's an alcoholic, but in his head, when he's in there for his 4th DWI or whatever, he's saying, he hears his mother's voice saying, you'll be a drunk like your dad. You'll always be a drunk like your daddy. And so we have to counter that if we're going to support them to break free from those shackles of hearing that over and over in their head and begin to make some decisions about their own personal value, self-dignity, and worth. And that links into that toxic shame again, where toxic shame I define as not just shame about what one has done in the past, but toxic shame is when a person feels that they are irrevocably damaged goods, that there is no hope for healing or rectifying what's happened to them and who they feel they are. So it's shame that a person has so deeply internalized that they cannot find their way out. And so this gets into, we don't know if a person has toxic shame until we really interview them well and support them to open up and talk about what it's been like for them as they've come through active addiction and possibly even mental illness. Counselors promote the well-being of individuals or groups of clients by developing and using appropriate educational, psychological, and career assessment instruments. And so recognizing that based on your certification or licensure, there are assessment instruments that you will be able to use within the scope of your license and expertise, and some you will not be able to. So those, most of the time, if you're interested in like a Beck depression inventory or a SASE, a substance abuse quantitative assessment, then as you contact that testing organization that produces that test, they will let you know, or on their website or on the test itself, it will say who can administer that and who cannot. And of course, it would be highly unethical to administer a tool that you're not licensed to administer. And of course, remembering that both educational and psychological and career assessments, all of those are pertinent to the needs of the client. You may have a client that needs a career assessment, but they don't need a psychological assessment. They're very bright, they've gotten some education, they now want to explore various careers that can be helpful to them. And so helping them make contact with someone who does career inventories and or accessing career inventories online, which there are ones that are for free and others that the client would have to pay for. So evaluation, assessment, and interpretation. We're going to explore, discuss, and list how evaluation, assessment, and interpretation are carried out in the counseling experience. And again, once you've done that assessment, that original assessment, which typically is a clinical assessment that looks at various symptoms of mental illness, it looks at addiction and substance use patterns and substances, it assesses for strengths as well as client struggles, successes, the evaluation, assessment, and interpretation. Explore and discuss and list how evaluation, assessment, interpretation are carried out in the counseling experience. I think this really captures how important it is to discuss any assessments, evaluations, and interpretations of them with the client. In other words, if you do an assessment, if you do a some type of psychological testing, or like a SASE assessment, an actual tool, that we don't just give that to the client and then never score it and counsel them about it, because they have the right to know what their test results are and how that needs to impact their needs assessment and or treatment. So whatever we do in the way of evaluation assessment, we must interpret it and inform them and then talk about how that would be used in relation to their treatment. So supervision, training, and teaching. Counselors aspire to foster meaningful and respectful professional relationships and to maintain appropriate boundaries with supervisees and students. Counselors have theoretical and pedagogical foundations for their work and aim to be fair, accurate, and honest in their assessments of counselors in training. Now, this is hugely important when it comes to, again, that power differential of supervisor and supervisee, that we provide some type of assessment of their performance, whether or an annual evaluation, certainly ongoing, maybe quarterly or twice a year or annual, so that supervisee, that counselor or social workers, they come up through their experience and their work, that they get the feedback they need to make changes. Without that, if a supervisor waited until the end of the year or the end of the supervision process to say, well, you really haven't met the criteria, or your performance, I'm concerned that you have problems in these certain areas, so I'm not going to recommend you for certification or licensure. That would be highly, highly unethical and not helpful. So, again, you don't have to judge that. You just have to wake up to that's not helpful to that supervisee. If our goal is, and we value shepherding individuals through the process of becoming an effective and valuable and heartfelt counselor, then we need to give them feedback and offer support and understanding and help them make corrections along the way, not wait till the end to let them know that you cannot support them with certification or licensure. This gets into also the impaired counselor or the impaired social worker, is that if you are a supervisor and you suspect a supervisee being impaired on the job, it's really important to explore that with them and work to understand what's happening. That individual may be experiencing pharmaceutical medications that are causing their behavior to be somewhat off or appear that they're impaired in some way. I think that it's really important to know the policy of your agency, to know the ethical guidelines of your certification and licensure board, and deal with impaired professionals kindly, appropriately, and professionally, just as we would treat a client or patient. Because if a professional is impaired, it means they're in an active part of their disease process. Once again, it does not make them a bad person or a bad counselor or social worker. It means they're back in the active part of their disease. And to support them to get the treatment again that they need so they can get back to doing what hopefully they do well in their profession is exceedingly important. I know that there's some very powerful thoughts and feelings that come up for co-professionals when they find that one of their own one of their coworkers is actively using again or has relapsed. So, again, having said that, I know there's a lot of strong feelings about that, but I go back to let's not pathologize or criminalize an impaired professional. Let's support them to get the help that they need. And certainly, let's not wait till the end of the supervisory process to talk with them about that. Supervision, training, and teaching, the counselor supervision and client welfare area. So again, we talked a little bit about we carry as supervisors vicarious liability. That means if I supervise a social worker or counselor and they provide care to 50 clients, I'm responsible ethically and legally for that care, for that counseling and social work that's carried out to those 50 individuals. Now, if I get to thinking about that too much, I don't get to sleep well at night. But I also recognize that I trust that those individuals that I supervise, as I talk with them every week, that if they have someone who is suicidal or struggling with addiction, or if there's neglect or abuse out there, that they will contact me right away. They don't wait till they see me a week later. They contact me right away by email or phone call, depending on the emergence of the situation. But that they understand what I need to hear from them about should something happen, such as a client suicide or abuse or neglect report that needs to be made for a particular client's children, that type of thing. So a lot of it is developing strong rapport with their supervisees and helping them understand what it is that you need to hear from them about so that you know what liability you are carrying for what they do. And even each from week to week, it's good as a supervisor to ask your staff any neglect or abuse reports, any subpoenas this week, any ethical possible violations, that kind of thing, to really keep everybody transparent and all issues out on the table, and especially ethical issues. Second is counselor supervision competence. And so that supervisor should be, if at all possible, a licensed or certified clinical supervisor who is trained in supervision, how to provide that, how to support the people that they supervise, to have and to display competence in supervision. David Powell, who was we call him the godfather, the guru of substance abuse clinical supervision. He died a couple of years ago, but he was excellent. He said in a training I attended one time, if we don't train supervisors, if we don't learn how to supervise, we will supervise the way that we were parented. And I don't know many people that want to supervise the way they were parented, because that's all of the model that we have in the way of the power differential and of authority, is we will end up utilizing how we were parented growing up as our model of supervision. So that stuck with me, that David Powell kind of horrified me, that we will supervise the way we were parented unless we have competence and training. Supervisory relationships should stay, again, with healthy boundaries, stay conscious and aware of possible boundary violations or breaches, and communicate openly about those. One thing, leveling the playing field, leveling the supervision, is instead of having them come to the supervisor's office for supervision, often going to the supervisee's office, or going to a neutral place such as a conference room, or if there is a confidential place, to go outdoors. I'm all about ecotherapy and eco-supervision. So I think that helps level the playing field and equalize the power differential a bit. Supervisor responsibilities. A supervisee should have informed consent for supervision and should sign a consent for supervision as well, so they know what to expect from their supervisor. And most certification and licensure boards require supervision, and they have guidelines around that and informed consents that they require be used prior to contracting for supervision. Last but not least is counselor educator responsibilities. So that's social worker, counselor, educator responsibilities. So that a lot of times includes college or university professors, adjunct instructors, and those individuals to know the policies, procedures, ethical guidelines, and responsibilities that they have towards those students. And again, that's healthy boundaries, advocacy, many of those same areas. And moving on now to research and publication. Counselors who conduct research are encouraged to contribute to the knowledge base of their profession and promote a clearer understanding of the conditions that lead to a healthy and more just society. And again, that's a very powerful statement, to understand, clearly understand the conditions that lead to a healthy and more just society, in which we see individuals who struggle with their mental health and substance addiction, that they have the right for treatment and to get on with the business of their lives, of meeting their full creative potential, advocating for that, making sure that happens. Counselors support efforts of researchers by participating fully and willingly whenever possible. So again, cooperating if it's a research being done and it advocates to identify client need or to identify and support particular therapies. If you were to be involved in that, that's certainly helpful in identifying and discovering evidence-based treatments. Counselors minimize bias and respect diversity in designing and implementing, again, research programs. So recognizing the ethical considerations when it comes to cultural diversity and respecting that. I think one thing I could probably share quickly that just came off the top of my head is a county in the area for years had a kind of one-stop shopping, Department of Social Services, food stamps, Medicaid applications, that kind of thing. We're right next door to the health department where families could get immunizations, physicals, could get their WIC support, Women, Infants, Children, food support. It was one-stop shopping. I think I said immunizations as well, well baby checkups, all those kinds of things. It was on the bus line. It was very supportive for those who are of low socioeconomic status, struggle with educational goals, to support them to arrive there and do all of their business for everyone in their family. And then I'm not sure what happened, because then they separated all those services, moved them all over town, and even one of them was not even on the bus line. So it made it next to impossible for those family members to get there. And transportation services in this area, being rural, was limited. So I think that's a really perfect example of where it's time to step up and say, that's not just, that is not justice, that is not fair, that is not appropriate, because those individuals now have to go to lots of different places. They often can't get there in the same day. It's just, again, it's setting up fragmented services that do not serve the people. So again, contacting your county commissioners, contacting the Department of Health, Human Resources, doing everything you can to support those services to come back into a place or area that supports equal access to those services. So again, there's so many areas for advocacy when we do wake up and notice what is both personally and professionally valuable to us about creating and supporting a just society and functioning within cultural competency as well. Resolving ethical issues. Counselors act in a legal, ethical, and moral manner in the conduct of their professional work. They're aware that client protection and trust in the profession depend on a high level of professional conduct. They hold other counselors to the same standards and are willing to take appropriate action to ensure that these standards are upheld. And so when we see ethical dilemmas, when we see ethical issues, when we notice things happening within our agency, our own clinical practice, that just don't sit right with us, it causes us to wake up in the middle of the night. It makes us uncomfortable. We have questions. We have concerns. That's a meter for waking up to, I need help. I need to advocate for these people who have less power than the people who are working with them. And so, again, going to a clinical or administrative supervisor, contacting a certification or licensure board, really stepping up to the plate and carrying that forth in a way that advocates for the person with less power, and that advocates for and carries out the ethical guidelines of your licensure or certification board. So here's some ideas about resolving ethical issues. First, we want to talk with the person that may have violated their professional ethics first, if it's safe to do so. Now, why would we do that? Well, because our personal and professional value says we all have the right and the ability to learn from our mistakes. And some people will violate ethics and have no idea that they have violated those ethics, because let's say other people in the agency have violated them in the past. Let's say in one culture it's okay, but in another culture it can be violating their ethics based on their beliefs. One thing off just the top of my head, and when I was much younger and I worked in a public health department, we worked with Latino families. Many of them were Catholic, which they did not want to utilize birth control, some of those families. when the husband and wife would come in, due to their culture and that period of time, it was culturally appropriate for me to only address the birth control needs of the woman with the husband. And so we would do that, and that was appropriate. And some of my coworkers who were very much into women's liberation said they weren't about to do that. They would talk to the woman only. And that did not go well. It really estranged some of the families, the men and the women. I got their personal and professional value of the woman having that right, but it was not culturally ethical to do that. Now, in some situations, what would happen is individuals would, the women would, let's say, come back for their checkup, their annual or whatever 6-week postpartum checkup, and they would say, don't tell my husband, but I'd like to have birth control. Then who's the holder of the right of confidentiality? It is the woman. So we would do that. We would follow through with her wishes. So in that particular situation, it would rise above or trump the cultural piece there. So again, gray areas of ethics, gray areas of that. So let's see, standards. So talk with the person that's violated. So again, the woman who was making that decision to say, I'm not talking with the husband, I'm only talking with his wife, she actually knew it was violating ethics, but overrode that. But it ended up that she was corrected around that, and she did follow those guidelines. So again, recognizing that some people will and won't know that they're violating ethics. I think the case study that we did earlier of the teenagers ages 13 to 17 that were placed in that 4x4 foot square to kind of contain them or even punish them for acting out or doing certain things, is that many individuals felt that was not an ethical violation. They thought it was very therapeutic, when indeed, if they were pressed, they could not show research evidence that it was. And in fact, they weren't able to show evidence that the children responded to that. And so again, though they were not aware that violated the child's client rights, they simply just weren't aware. They weren't conscious that that was a violation. So once again, talking with them about that, if they disagree, I'm going to do this anyway, then you have to go above their head to address that. So the next level of resolving ethical issues is look at the standards of the agency, look at the standards of practice by their certification or licensure board, and to look at the laws that bind them. I got a call recently where a supervisee had met all of her hours for a particular certification board and had stopped supervision. And her supervisor called me and said, I just have a question. Is it true that once they meet their hours that they can stop supervision? And I knew the answer to that very quickly, and that's true as far as I know for any licensure or certification board. No, until you have that license in your hand or have been notified by email or snail mail that you are fully licensed, you must remain under supervision until you are deemed fully licensed by that certification or licensure board. So again, that's an example of law. That's not ethics. If you're an associate, like an LPCA or an LCSWA or a CSAC-A or a CSAC-R, any of those, that means that you have all the rights and responsibilities of a fully licensed clinician. However, that is only under supervision. So if you stop supervision, then you're practicing without a certification or license, which leaves you open to litigation. So I wanted to be clear about that. Standards and the law are the next step. So as you're resolving ethical issues, if you can't resolve it with the person, let's say can't find the standard or the law, And if it's an ongoing suspicion of or suspected violations, then going to, again, administrative staff, clinical, or administrative supervisor. If that doesn't get resolved, then moving forward with more administration or higher administration. Higher administration often will contact their corporate lawyer or the attorney for that agency to see if it is in legal violation, and then contacting your licensure board to say, just want to check this out. Can a person do this? And then acting based on that. With suspected violations that are unresolved, you must report that to the licensure or certification board or suffer litigation if it's discovered. So as you're completing that report, most websites, certification board or licensure websites have an affidavit or a form that's filled out, may or may not require notary, and then that is sent immediately to the board, and they review it and then make a decision about whether or not they'll investigate it. If they do investigate it and wrongdoing or ethical violation is found, then they will take appropriate action to suspend license until certain criteria are met. So cooperation with, again, ethics committees. As you send that application into ethics committees, they may call you in to not testify, but to answer questions about what you've placed on that report. And so we're now to the point of resources, and before we move towards identifying those, we'll take just a moment to stop. All right, and welcome back. We're going to look at statistical data on the most frequent ethical violations in counseling. And why would this be important for us to take a look at? Well, because the most frequent ethical violations are what we're most likely to infringe upon. And so if we know that, we can be sensitive and aware to those particular areas that are violated most. And this is, I want to source the credit for this. It comes from www.tenn, that's short for Tennessee, legal, legal.com. So that's www.tennlegal.com from Tennessee, from one of their state boards there. So as we scroll down on this article, it shares data from various professional organizations, ACA, American Counseling Association, American Psychological Association, and others. And it says that the ACA, the American Counseling Association's 10 most prominent ethical issues are, and these are not in order of frequency, they did not list that, are clients' rights, violating informed consent by clients or patients, ethical issues with multicultural counseling, so issues around not observing and adhering to cultural diversity. Another one is confidentiality. Another one, competence, competence of one's practice. Another one is working with multiple clients, couples, and groups, not adhering to guidelines around working in group dynamics and with couples. Another one is counseling minors, and I bet a lot of that has to do with consent, again, making sure that parent consent is there, and if it is concerning drug addiction or other types of counseling where there's state laws that protect minors, you would need to know that based on your state. Another one is dual relationships. In other words, whom I might be counseling shows up one day and is painting my house, and how I would deal with that. So dual relationships. Working with suicidal clients. And so it'd be interesting to see how some of this fleshes out. Counselor training and supervision is another topic. And last but not least is the law and ethics. So those are the 10 most prominent ethical issues that are violated. And so let's look at the most common ethical complaints filed with American Psychological Association. Sexual misconduct with adult clients was 29%. Now that's pretty shocking, because that's 30% of the number of complaints filed with the APA. Second is insurance and fee problems, coming in at 21% of the complaints filed. Child custody evaluations, coming in at 10% of complaints filed. And then there's a other category. It doesn't say clearly what it is, but it says other, having to do with professional misconduct, is 10%. And then it drops off pretty quickly. Sexual misconduct with minors at 7%, non-sexual dual relationships at 7%. Practicing outside of one's competencies is 5%, and inappropriate follow-up and termination of client services is 5%. And I kind of suspected that because I think that sometimes is quite a bit of the shortcoming of folks, is when we have a client that doesn't show up, it's not a time where we go, oh, they're just not interested in treatment. That may not be what happened at all. That client may be not well themselves in some way, that they need a reach out, and making sure that they know they are welcome to come back for services, referring them, giving them a couple of referral sources in case they weren't comfortable with that particular agency, or perhaps they even came to substance abuse intensive outpatient and someone they knew was there and they don't want to come back. And especially if they came there and somebody who had perpetrated them was there. So again, the most common ethical complaints filed with the APA, being aware of those topics and monitoring your own professional practice. Moving on to data from various state licensing boards. This is a national survey. Most common ethical complaints that are actually do go to state licensing boards. Practicing without a license, 27% of the complaints were about people who were practicing without a license. Second, at 20%, is sexual relationship with a client. So I think it's probably more predominant than we realize. And really having clear boundaries, holding those boundaries. And if we think about this, a counselor or social worker relationship or therapist relationship with a client may be one of the, if not the only, first relationship that client has had where someone truly cared about them. And that can be mistaken for a sexual relationship or one of intimacy leading to a sexual relationship. So moving on to another one is the category of other, poor standard of care, violation of ethics codes, inadequate supervision. So again, when you think about many folks getting out of school with LPCA, LCAS-A, LCSWA, those are all full licenses. An associate license is not a license that is, the word slipped from my mind, it's not it's a full license. It's not a license that's let me just back up a second. So it's not restricted in any way. It's a full license. Thanks, John, from behind the camera. So when you have an LPC or LCAS-A or LCSWA, you have all the rights and responsibilities of a fully licensed counselor as long as you're getting supervision. And if you're not getting supervision, then you're practicing without a license, because that is the restriction. That is the only restriction. So you have a full license, but it's contingent upon that supervision. And some folks forget that. So really knowing the state laws around that, if it's 1 per 40 or 2 per 40, 1 hour of supervision for 40 hours of practice, or 2 hours of supervision for 40 hours of practice, and really adhering to that. The third one is inappropriate fee assessment, 12%. So charging differing fees to people, not letting them know what the fees are ahead of time. Dual relationships, it doesn't spell that out, but with 7%. Failure to inform clients of their goals, techniques, counseling techniques, rules and limitations of counseling is 7%. And one of the good things about being part of a state board is when you give a client that informed consent, on that should be your rules and limitations of counseling and your clinical expertise and that kind of thing. And then moving on to, this was kind of surprising, only at 5% of the complaints was breach of confidentiality. Failure to report abuse, doesn't say child abuse, just abuse, was 4%. Failure to report clear and imminent danger, and that's harm, that client's going to harm someone else, is 2%. And failure to properly form and facilitate groups, i.e. group therapy, was 2%. So again, remembering to hold that group structure, be clear about your curriculum, use group rules and guidelines. So this is interesting, disciplinary action taken. They recorded that 34% had their license revoked or suspended. So that again is a number to take very seriously. That's over a third had their license either suspended or revoked. And at 27% was other action, such as a letter sent or placed on probation, of course with restrictions. 26% of the complaints formally investigated were dismissed, so that's a plus when they were investigated. 11% were reprimanded, and 1% were assessed a fine. So some states actually have a fine in response to ethical violations. And so as we move on down through this article, guidelines for avoiding the most common ethical violations. Here are some ethical tips. That's just for school counselors. Let's scroll past that. So here's some tips by the American Psychological Association for avoiding ethical pitfalls. The first is understand what constitutes a dual or multiple relationship with that client. Whose needs are being served, and is the client being exploited? So those are two questions to ask yourself if you experience multiple relationships or dual diagnosis. Whose needs are being served, and what client is being exploited? And is the client being exploited? Protect confidentiality. Discuss limits of confidentiality, especially with the individual in groups, such as, again, the sexual abuse, neglect, that kind of, or abuse and neglect. Ensure safe storage of records. Your records should be locked away safely, double locked. Know federal and state law. Is there a law requiring disclosure of those records? And if there's laws requiring disclosure, typically it's going to be around the legal system, where, again, knowing the difference between an attorney's subpoena and a judge's subpoena or court order. You must always respond to a judge's court order. If there was suspicion that that judge was prejudicial in some way or jaded in his or her practice, then your agency would need to contact their attorney, that information shared, and that client's record could be withheld until pending investigation. So and that has actually happened before, where in certain areas in our country where there is persecution of people of color or people of other cultural backgrounds, that if a judge was to order that court record, that can be challenged by the agency's attorney and another judge. So being aware of that. So obey mandatory reporting laws of abuse and neglect. It is not uncommon to hear from professionals that they don't report child abuse or neglect because they feel like DSS won't do anything about it, or they'll alienate the parents who are coming into treatment. But that is no defense in a court of law if a counselor or social worker, other professional, does not report abuse or neglect. And remembering your license is at stake if you breach the law. Ethics, there's some gray areas there, but with the law it's pretty black and white. So another tip on avoiding ethical pitfalls is obtain informed consent at the start of treatment. Fourth is identify your client and the role you have with that client. Understand who you were hired to help and what is expected of you in helping that client. A good situation, not good, but a good case study is years ago I was working at an agency, and they had substance abuse intensive outpatient in the afternoon and evening. And the evening group was for people that were employed and needed that group, but certainly anybody could attend. And one of the substance abuse counselors was doing an assessment, and I overheard him or her say, if you can't come to daytime IOP, you can't come at all. And the gentleman said, well, I work and I can't do that. And he said, well, that group is full right now, so you wouldn't be able to come. And I don't need to do an assessment with you if you can't come to day substance abuse intensive outpatient. And my heart sank when I heard that, because it would be up to that substance abuse counselor to follow through by doing an assessment and then placing him on a waiting list for SAIOP in the evening, or referring him out to another evening group at a different agency. It would not be a good reason to not do his assessment, refer him out, or give him options, because when a person is seeking treatment, that's when we need to work with them. And in the by North Carolina's law, there is no closed door. All doors are open. If someone were to come before you and they didn't have a substance abuse problem and they wanted a mental health assessment, it's important to go ahead and do that assessment and then get them referred within your agency to the appropriate services. So there's no wrong door. I believe it's no wrong door policy is what it's called here in North Carolina. And that means, too, if somebody is doing assessment and a person says, I have a substance use disorder, they can't stop the assessment and go, I can't do your assessment. I've got to send you over to the substance abuse person that does those assessments. They should finish that assessment and then make the appropriate referral. Let's see, number 5, document properly. And so your documentation guidelines you want to pull from your agency's policies and procedures. For many, with the managed care organization, I think it's 36 hours, or used to be 36 hours to complete your notes. Some places it could be 72, but just know your agency's protocol. In some agencies it's 24 hours. And so far as protocol for making a report about abuse and neglect, it is within 24 hours of having knowledge of possible abuse or neglect. So that, unless that law's changed, you have 24 hours. But you wouldn't want to take that much time if it was someone who needed assistance or support or help right away. Practice only where you have expertise. Again, that scope of practice. Know the difference between abandonment and termination. Treatment can be discontinued when clients are not benefiting from treatment, but they should be referred out. They may be harmed by that treatment, or the therapy is no longer needed. And last is if they threaten the counselor. So the difference between abandonment and termination, clients who abandon services and when they must be terminated for any of those reasons, especially when safety is a concern for the counselor or other staff or clients in the agency. Last, under abandonment and termination, is pre-termination counseling involve the client in the process. So again, a good example is someone who's a substance dependent client or substance abuser, and they keep having positive drug screens or screens for alcohol or breathalyzer. If they're not able to stay clean in outpatient therapy, then pre-termination counseling would be very important to talk with them about that we feel that since you've not been able to attend regularly or you've had positive drug screens, that we invite you or refer you to a higher level of care where you're more likely to be successful at getting clean and staying clean and benefiting from treatment. That is very different than someone being punished for having positive drug screens that then is terminated and told you failed your treatment. Which is not therapeutic at all. We know that relapse can be and often is part of that disease. So really being aware to do pre-termination counseling, referral, tell them this is not the end of their treatment, that this is a reevaluation of what would be most helpful for them. And of course, if you look at ASAM guidelines, American Society of Addiction Medicine, their guidelines for levels of care and stages of treatment and all of that, it's important to really use those ASAM guidelines to support you. Number 8 here is stick to the evidence when giving an expert opinion or conducting an assessment of a situation, whether it's ethical or legal. As David Powell used to say, who was the father of clinical supervision and substance abuse, he'd say, "Just the facts, ma'am." It's kind of like you're a highway patrolman and some lady's telling this long story and the highway patrolman says, "Just the facts, ma'am." And so when it comes to being an expert witness or testifying in court, you want to prepare yourself, you want good notes, you don't want to walk in there unprepared, and look at just the facts. Identify what you do know and what you do not know, and get some coaching from your clinical supervisor or someone else who has been to court and has that experience. In some situations, high-profile cases, often the attorney of the agency may work with that counselor to prepare records and or testify. Last but not least is be accurate in billing. Keep records and discuss billing up front with the client. And this is really, really important when it comes to billing Medicaid, Medicare, and insurance companies to follow their guidelines and to be very specific about what they're willing to accept and not, and document that. I know that some insurance companies will often contact counselors to say, what's the status of this client or patient? If we're going to continue to pay, we need to know how that client or patient is responding to treatment, what they're still receiving, not receiving, that type of thing. And that often gets a little sticky about what can be shared and what can't. Again, sharing with them diagnosis, participation in treatment, what they're attending, what they're not, but sharing details about what they're in therapy for would be a breach of confidentiality. So if you have someone call from an insurance company and they seem to be just a little bit too nosy and asking questions that are more about content than about participation in treatment, then just tell them that you'll need to get back with them and you want to talk with your supervisor immediately about that. So in conclusion, statistical data on ethical violations has the potential to be one of the most powerful preventive tools. Presently, the data available is somewhat limited. Some states keep that data, others not. There's a national effort to collect and analyze accurate figures to support the prevention of ethical violations. As it stands, the very, very best way to be able to pursue best practice and continually strive for honest self-appraisal is to also keep the client's needs as your top priority and to familiarize yourself and them with the professional code of ethics and their client rights, and to know and practice the state rules guiding your practice both at the agency, the county, city, state, and federal level.